In order to treat the combined movements, I will have to put her into the combined position, to the barrier of the combined position. So I'll just bring her back onto her side. Now, let's assume that what I want to regain is extension and left rotation. Then I'll bring the arm way back here, and this arm I will pull straight up to the ceiling, like so. In the legs, I will straighten the bottom leg out for me, there. I will extend here through the segment, way through the segment. This isn't locking now, I'm taking the whole segment into that position and bring the pelvis forward so she's rotated. So she's maximally left rotated and extended. And now in this position I can treat this, again using the hold, relax, oscillations and so forth. And I can simply do the arthrokinematic movement and draw this through a body. Now, the natural plane of these joints will result in actually its side bending in this direction. And I think that you might be able to see this as I do it. There. Okay? But there's no need to try and produce that side bending. The arthrokinematic glide, which is roughly in line with a femur, will produce the appropriate side flexion rotation. If I wanted to regain flexion and left rotation, then to position her at the flexion barrier, I'll allow this arm to fall forwards, like so, and this arm I will draw straight out, horizontally with the bed. Have a hold her wrist, straighten your bottom leg out for me, and then I will flex this leg up and rotate it. So she's maximally flexed and rotated to the left. And the technique is essentially the same again. But now, because of the orientation of these facets, this will produce the opposite side flexion to what we was just getting. Okay. Come back onto your side for me. Now, we can treat symmetrical dysfunctions with bilateral asymmetrical techniques, which are often very effective and the more effective way of doing it. But we can also use other techniques. And for these, we're going to need to lock the spine. Now, when we lock, we'll lock in rotation and side flexion, and then either flexion or extension. And I think the first technique I'll demonstrate this with will be specific traction. Let's assume that I'm going to do specific traction to an area somewhere around about L3, 4. In order to do this, I will have to lock down and lock up, so I can lever through these two regions, but at the same time leave the segment that I'm treating in neutral. So, I shall choose to lock in extension from above below. I could choose flexion, but I've got a preference for extension. So I will palpate, if I'm treating L3, 4, I'll palpate L2. And I'll produce an extension left rotation by pulling this arm straight up to the ceiling while this upper arm is behind her back, like so, until I feel L2 just start to move. I will then continue the lock more specifically here by just rotating back until I feel L3 just start to move. From below, I'll lock in flexion first. So I'll flex up and feeling for L4 to start flexing, and then I'll just back off a little. I'll have the patient straighten the bottom leg and relax and complete this lock by rotating the pelvis towards me, and again until I feel L4 just start to move, and then stop the movement there. And then I can stabilize the pelvis with my body so it doesn't go any further. Now, the bottom leg, I will have her push out straight as hard as she can, really stretch it, keep stretching, so that she side bends the pelvis up as she does it. I shall then reach in and stabilize the pelvis into left side bending. She can then relax her leg, and I shall trap the pelvis here. And I'll apply the traction by pushing off from my left leg, in this case, pushing down the bed. And as I do so, any side bending that occurs at the pelvis now will simply move it back to a neutral position rather than actually side bending it to the right. And the traction can here be graded, depending on whether I'm treating for pain or for stiffness or even for a disc problem that I want to treat with specific traction. In order to use other treatment techniques, the locking is exactly the same, except that we don't extend the lower leg the way she was doing it by pointing down, as the side bending isn't a major factor. But having locked her up and down, I can then take this pelvis into a little more flexion if I want to treat for flexion, like so, and then I can produce a pelvic flexion mobilization simply by twisting my body to the right. As I stabilize the superior vertebra with my hand, I shall be pulling on this inferior vertebra and localizing the force. If I was to want to produce extension, then the lock in the leg would be done in extension rather than flexion. I would extend the pelvis a little more and produce the extension by twisting my body to the left, like so. While at the same time, I can produce the arthrokinematic glide by putting my fingers on either side of the spinous process and pushing this anteriorly and superiorly. I could treat side bending simply by locking to that segment, not flexing or extending through it, and coming onto the pelvis again in the same manner as we tested, and side bend in this direction if this was a movement that was restricted. Of course, I can do the side bending with an asymmetrical technique similarly, but if I had, for example, flexion and side bending to the right was restricted, then I would have that segment in flexion and then side bend this way. Alternatively, if it was an extension side bending restriction, I would put the segment into the extended position and side bend. So there's a good deal of flexibility that's available to you with these treatment techniques, and you need not be confined to one particular type of treatment or another. Flexibility is everything when it comes to treating the spine, because you have to be able to adjust for a particular patient, and also if the patient does not allow you to put them into that position because of soreness or an instability elsewhere, then you need to be able to change your approach to protect that sore or hypermobile or unstable joint. Thank you. Now, just to wrap up the principles on this testing all the way through the spine, we're looking at, initially you would actually do passive physiological mobility testing to determine whether or not you have a restriction of movement or an excessive movement. If it's a restricted movement, you would then, when possible, come in and do the arthrokinematic tests, which would help you determine whether you're dealing with a articular or a myofascial hypomobility. You should also be able to determine whether you're dealing with a symmetrical, that is a uniplanar dysfunction, or an asymmetrical, a triplanar dysfunction, and the treatment technique that you select will depend on those findings, whether it's a muscular treatment or whether it's an articular treatment, and whether it's symmetrical or asymmetrical. Alternatively, the passive physiological movement test may have determined that you have a hypermobility or even normal mobility, in which case your next move would be to do stability testing to determine whether it's simply hypermobile or whether it's hypermobile and unstable. And the treatment techniques for these are much more complicated, much more labour intensive, and will be dealt with on another tape.